Thanks, Jeremy. As always, thank you for having me, and this time in particular, getting me to do a talk in an area I don't feel very comfortable in. Most of my work really is focused on age-related mycoses and fungal infections in hematology, a little out of my comfort zone, but I found this a really interesting area. And in fact, what I'm going to do today is talk to you about various aspects of fungal infections in hematology, but using a case presentation, a case on which I was recently consulted. So just to get started, I'm going to take you through the case background, and just to say at the outset that the case information is really courtesy of Juanita Lishman and Clinton van der Westhuizen, both at Tygerberg Hospital. So the case was of a 5-year-old girl diagnosed with severe aplastic anemia in July 2021. She had genetic analyses done which were negative for Fanconi anemia, but she did require monthly blood transfusions and was started on chelation therapy. She also received ATGAM, which is antithymocyte globulin, in January 2022, and also cyclosporin without improvement. The ultimate plan was really for stem cell transplant. She had HLA tissue typing performed and some potential donors were identified. So the first point I really want to discuss is when to consider primary antifungal prophylaxis. And this is from a recently published guideline focused on pediatric hematology, which says that primary antifungal prophylaxis is strongly recommended for children at high risk. And so the incidence, high risk essentially means where the incidence is more than 10%. And this usually occurs in the context of patients with acute myeloid leukemia, recurrent acute leukemia, high risk ALL, patients who've had a stem cell transplant either pre or post graft, and also in the context of graft versus host disease, particularly where immunosuppression is being augmented to control or avert graft versus host disease. And the antifungal agents which are usually recommended are either fluconazole or posaconazole. So fluconazole is active, as you know, mostly against yeasts, and so that's generally only going to be used where the incidence of invasive mold infections is low, or if you're going to actively exclude mold infections if you give fluconazole prophylaxis. Fluconazole prophylaxis is also not recommended in the stem cell transplant situation post-engraftment because of the high risk of mold infections in this setting. So if you are not going to use fluconazole, then posaconazole is the other option. And this, of course, is a much broader spectrum triazole, and the spectrum includes both yeasts and molds. Now, when you are trying to decide on, who is at highest risk for an invasive fungal infection, there are multiple factors to look at. So I've taken the example of a patient with a stem cell transplant and essentially looked at various categories across patient factors, comorbidities, immune status, environment, neutropenia, the actual hematological disease, treatment, as well as any transplant. So for instance, you can see that if you've got an elderly person, more than 65, who has had a stem cell transplant, they are at increased risk for an invasive fungal infection. Similarly, if they've had a previous invasive fungal infection, or if they've got prolonged neutropenia with the cell counts less than 500 for a prolonged period, or if their hematological disease is active, and also various other factors relating to the treatment they're on, and also the relating to the transplant. So this is a really nice table. you can expand it out to every type of hematological malignancy, and you can actually work out when people are at high, intermediate, or low risk of fungal infections. So let's move back to this patient. So in June 2022, she was admitted with an intraorbital bleed into her left eye caused by a severe thrombocytopenia. There was no clear evidence of trauma to that eye, and she had emergency surgical decompression performed by ophthalmology. A couple of weeks later, she was then readmitted with fever, severe anemia, epistaxis, a reduced Glasgow coma scale, and she then received platelet and blood transfusions and was started on empiric piptaz and amic to cover a nosocomial infection. At this point, her CRP was elevated, 193. She had a very low total white cell count of 0.9. Hemoglobin and platelets very low, as you'd expect, given the aplastic anemia. Her neutrophil count was 0.05 and lymphocyte count 0.81. So the one thing to ask, and an interesting question to consider, is could you use a CRP and procalcitonin, the combination of those two biomarkers, to point to an invasive fungal infection in an immunocompromised child over a bacterial infection, for instance? And there are data to suggest that in the context of fungal infections, you see higher CRPs and lower procalcitonin levels. In this study, which included, I think, approximately 120 patients, they looked at the median CRP and procalcitonin levels in patients with invasive bacterial versus fungal infections. And you can see that the CRP was higher in the fungal group, but lower and lower in the bacterial group, and conversely, ECT lower in the fungal group and higher in the bacterial group. But again, you can also see that there's a lot of overlap. When they looked at the area under the curve, plotted these receiver operating characteristic curves, you can see that the AUC for CRP alone was 0.78, the procalcitonin 0.73, but the combination of CRP and PCT was actually quite useful, with an area under the curve of 0.93. So it is possible to use that combination, but it obviously is not. It's not the end of the story. So clearly, more investigations need to be done. So a question to the audience is: how would you investigate fever in a child with prolonged neutropenia? So just feel free to just add some investigations into the chat box. I'll have a look to see what people suggest.
So go wild in the chat box.
Thanks. I think blood cultures, urine cultures. Thanks. That's great. Absolutely. So, the clinical examination, etc. So what I've done here on this slide is just summarize how you can focus your investigation. Clearly, one would almost always order central and peripheral blood cultures, particularly with a recent admission, as in this patient, and especially if the patient's got vascular catheters in place. If there's mucositis, you could order oral swabs for HSV, for fungi. If there's any evidence of abdominal tenderness, obstipation, an ultrasound may be useful. For lower respiratory tract symptoms or signs, CT chest, sputum cultures, nasopharyngeal swabs for viruses, including SARS-CoV-2, a urine Legionella antigen, particularly for patients, recently been admitted from the community or has been in hospital for some time. Urine cultures, if that's indicated. Stool cultures are sometimes ordered in hematology patients, really not mostly to determine whether the patient is colonized with a multi-drug resistant organism. If there's skin or mucosal lesions, you can, of course, do tissue biopsies, direct microscopy. And if there's any evidence of cardiovascular involvement in echo, any involvement of the CNS or sinuses, an LP and CT head. So, you can actually, there's a broad spectrum of possible investigations, but really it would be directed by your symptoms and signs. In this particular patient, her COVID-19 antigen test was positive, and she also had positive blood cultures. She cultured an Enterobacter cloacae, which was multi-drug resistant, susceptible to Neutropenia and Meropenem. So the problem in this patient, though, was ongoing temperature spikes despite broad spectrum antibiotics. So she was in PIPTAS and AMIC. She was then changed in response to this Enterobacter cloacae, changed to Meropenem, but despite the Meropenem, she had ongoing temperature spikes. So, of course, when one looks at approaches to fungal infections, this is a useful table I found in an article from about 10 years ago, essentially summarizing what you have in terms of radiology and clinical symptoms, mycology cultures, mycological and clinical evidence of an invasive fungal infection, and then your final diagnosis and what you do. We're essentially at this point here where this patient has a persistent febrile neutropenia. We don't have any clinical mycological evidence of an invasive fungal infection as yet, and so we're moving towards empirical treatment if this prolonged neutropenia with persistent fever remains. Of course, as you move to the right of this table, you can then move on to another approach, which is known as the diagnostic-driven or preemptive treatment approach, using biomarkers to identify, an earlier point at which you can initiate treatment. And then, of course, once you start developing, a patient develops radiological signs, and then there's clear evidence of an invasive fungal infection from using biomarkers or from tissue specimens, you then move more towards targeted treatment. But of course, on the right-hand side of this table is a much smaller proportion of patients. It's much harder to make a firm diagnosis in patients with severe immunosuppression. So in this pediatric guideline I mentioned earlier, they discussed these two broad approaches to antifungal treatment. In general, if you are using empiric antifungal treatment, this would usually be directed to patients with granular cytopenia at high risk after 96 hours of fever of unclear cause that's unresponsive to broad-spectrum antibacterials. The second option, which is the preemptive diagnostic-driven therapy, is great and works, but really, in order to do this, you need rapid availability of CT scans, you need rapid availability of serum and BAL galactomannan. You also need capabilities of performing bronchoscopy with a BAL to be available so that you can perform galactomannan testing on that BAL specimen, mostly because the sensitivity of galactomannan on serum is lower, particularly if you've got a patient on mold-active prophylaxis. So in this patient, she was started on fluconazole. The unit in which she was in mostly sees invasive candidiasis with a relatively low incidence of invasive mold infections. And so the first-line empiric treatment is usually fluconazole. As I mentioned, she was changed to meropenem in response to that positive blood culture, and vancomycin was also added. She continued to have temperature spikes. There was a concern of multi-system inflammatory syndrome in children, or MISC-C, given her COVID diagnosis and raised inflammatory markers. She had no mucocutaneous or other features of MISC-C. There was a normal echo, but she was then given polygam. At this point, her CRP had increased to 316. They had a serum procalcitonin at this point of 1.14. Her white cell count had decreased even further, with a neutrophil count now of 0.02, lymphocyte count, which was low again, 0.45. And of course, following on the transfusions, hemoglobin and platelets had increased. You can see that she clearly was iron overloaded with a ferritin of 8208. Her CRE rectal swab was negative. On the 18th of July, new skin lesions were noted by her mom. On clinical examination, she had no respiratory or focal neurological signs. There was no sinus tenderness. She had abdominal tenderness, but not peritonitis with hepatomegaly. And she had purple palpable papules with a diameter of 5 to 10 millimeters on both her abdomen and limbs. So this is not the image. These are not the images from this particular patient. We weren't able to contact the parents to get permission to share the images in time for this presentation. So I'm just showing you some generic images from another patient, a case presentation that was, I think it was an image of the week in the NEJM a couple of years ago. So what do people think in terms of differential diagnosis here? I see Lauren asks if they were tender. I asked the same question, and I don't know. I don't know if they were tender. Any thoughts? What would your differential diagnosis be? Erythema nodosum, I assume, yeah. Okay. Atypical mycobacteria to the corpus histoplasmosis. Okay, good, thank you. I've just put some possible diagnoses down here. I put fungal first because this is this is all about fungal infections and hematology. And so, of course, you know, there are bacterial and viral causes, and there are non-infectious causes too. And in terms of the fungal infections that you can consider, these would include Fusarium and other hyaline molds, Candida, Cryptococcus, and rarer yeasts, pigmented molds, mucuraceous molds, as well as the endemic fungi, including histoplasma. So I just wanted to briefly take you through fusariosis, which classically presents like this among patients with profound neutropenia. And what you can see, usually you have positive blood cultures. And what you see in the skin are these lesions with an ulcerated center surrounded by an erythematous halo. If a tissue sample is submitted to the laboratory and digested using potassium hydroxide, what you would then see a hyaline septate hyphae, which you can see on figure B. And you can also see that they branch at acute angles. On histology, you'll see a vasculitis with thrombi, sometimes, or you should be able to see hyphae in the tissue. And then on culture of fresh tissue, you should be able to grow Fusarium. And microscopically, this is usually what you'll see under the microscope. When you examine this colony microscopically, you see classically these banana-shaped macroconidia and hyaline hyphae. And when you examine the tissue section and stain using a special stain such as the Grocott stain, which you see here, you will see hyphae again, acute angle branching occasionally, but septate hyphae. There was a recently published guideline, 2021, talking about the diagnosis and management of rare mold infections, including fusariosis. And in order to make a diagnosis of fusariosis among patients with hematological malignancies or neutropenia, clearly one of the diagnostic interventions would be a CT scan, because fusariosis can involve the lungs and other systems. Galactomannan is useful. This is the Aspergillus galactomannan assay in serum, because there's some cross-reaction with fusarium. The beta-glucan assay is a pan-fungal assay, is marginally recommended. And of course, the best methods are the classical methods. Well, in terms of specificity, at least, direct microscopy and culture. And of course, as I mentioned, fungal blood culture and histology. In terms of treatment of fusariosis, the recommended treatment is amphotericin B, liposomal amphotericin B or lipid complex, alternatively voriconazole. And if required, surgical debridement may be needed, particularly in localized infections. And if there's a response in some patients, combination treatment can be used. So in this patient, on the 20th of July, they were still waiting a dermatology consult. There was, of course, still a broad differential diagnosis, and so they hadn't changed any treatment at this point. Colistin was added with ongoing temperature spikes. The patient then had a repeat chest X-ray which showed bilateral infiltrates. So the question is a chest X-ray sufficient? Would you do any further imaging? Again, I'll look at the chat box to see if anyone has any thoughts.
I'm going to shout at my Vidsregis if they give the wrong answer.
Good. So Lauren and Alicia saying iris CT. Yeah, you do need a CT scan. And from this guideline, so this is the patient's chest X-ray. You can see there was a bilateral infiltrate. I don't think that there was evidence of pleural effusions, but essentially the guideline recommends that you need a high-res CT in this group of patients at high risk with febrile granulocytopenia that persists for 4 days or more with focal clinical findings. And if they're both either typical or non-typical pulmonary infiltrates may indicate a pulmonary invasive fungal disease, and that should prompt further diagnostic testing and initiation of mold-active antifungal treatment. So in this patient, they started azithromycin to cover an atypical bacterial pneumonia. They did a Legionella antigen test, which was negative, and also a TB LAM test, which was negative. They also ordered a serum galactomannan test, which was negative. This is the specific Aspergillus galactomannan assay. Do you think this excludes Aspergillus? Okay, I'm looking at the chat box again. Yeah, so it's not perfect, and you're right. The patient's been on some antifungal treatment, and it's possibly not enough. I mean, it's got a reasonable negative predictive value, but it doesn't completely exclude aspergillosis. As I also mentioned, a serum test has much lower sensitivity than a bronchoalveolar lavage test. Let's quickly talk about Aspergillus galactomannan antigen. This is a cell wall antigen, which essentially which is composed of galactofuranose components with a mannan core, which are released during hyphal growth. And here's a picture of the cell wall. That's the membrane here. This is the cell wall of Aspergillus fumigatus, the hyphal form or the filamentous form. And what you can see is that galactomannan is found in the cell wall. And it's essentially, as I said, released during hyphal growth. It's detected using an enzyme immunoassay. Also, there are some latex tests, and there also are now some lateral flow devices which can detect this antigen in serum or bronchoalveolar lavage or CSF. The serum OD index cutoff is 0.5 versus BAL CSF where the cutoff is 1. And just remember, they might be false negatives, particularly in early infection. When you're looking at serum galactomannan, patients with invasive disease may have intermittent antigenemia. And of course, if you're on mold-active prophylaxis, which this patient wasn't on, that would reduce the sensitivity dramatically. Aspergillus fumigatus also, this test has a lower sensitivity for detection of fumigatus versus other species complexes. And then, of course, there are some false positives. As I mentioned earlier, there are cross reactions with Fusarium, Penicillium, Histoplasma. Treatment with beta-lactam antibiotics can lead to a false positive result, as can treatment with Plasma-Lite. Patients post-stem cell transplant, those with gastrointestinal mucositis, can also have a false positive result because of translocation of galactomannan found in food, etc., and also fungal components in the gut, which can then translocate into the blood and cause a false positive result. So what's the recommendations for galactomannan? It really depends on whether you're using the galactomannan antigen in the context of the screen and treat approach versus the empiric treatment approach. So let's leave the screen and treat approach because I don't think that's very well developed for pediatrics. We're in the context of this case, we're looking at this in terms of its diagnostic utility. So, as I mentioned, the OD index is 0.5 as a threshold for positive result in serum, and in BAL it's 1, and similarly in CSF it's 1. And you can see that in general, this guideline group gave an AT recommendation for use of galactomannan, preferentially using bronchoalveolar lavage specimens. So in this patient, fluconazole was stopped, and she was then started on broad spectrum amphotericin B in view of these ongoing temperature spikes and chest X-ray findings, despite the broad spectrum antibiotic cover that she was on. Remember, she was on meropenem and vancomycin. A day later, TB treatment was also added. So she's now on meropenem, vancomycin, amphotericin B, and TB treatment. And she continues to spike temperatures. Okay, so now, in this particular patient, we've got these skin lesions. It is really important to investigate this further. So on the 22nd of July, a skin biopsy was performed by dermatology, and this was submitted for histological examination. What would you expect to see, assuming that this was a fungal infection? I mean, you could see all sorts of things, but what do you think this could be if it was a fungal infection? Hyphae, yes, you could actually see hyphae. Okay, so I haven't given you much else of it. So remember that we said on the differential diagnosis in terms of fungal infections, you really have to consider Candida and rare yeasts. You must consider hyaline molds, mucoraceous molds, as well as pigmented and dermatiaceous molds. I think in this patient, the most likely scenario it's very hard to tell. I would have guessed high-line moles, as I said, fusariosis most commonly. So I really would expect to see non-pigmented high-line septate hyphae with acute angle bronzing, which is what you expect with a high-line mold infection. Remember, with a candida or rare yeast infection, what you expect to see are yeasts intermingled with pseudohyphae and hyphae. With mucorrheious mold infections, you'll see high-line hyphae, but these tend to be broader, ribbon-like, with right-angled branching. And then if you've got a pigmented or dermatiaceous mold infection, you're going to see pigmented, irregular hyphae and yeast-like structures, both with septations. Okay, so this is what was actually seen. This is what they saw on the H&E stain off the skin. The first thing they noticed was these round elements here. So then they noticed an area of necrosis. And when you zoom in, you see these round fungal elements, which are consistent with yeasts, and they didn't see any hyphal structures on H&E stain. The histopathologist did say that in some parts of this biopsy or these tissue sections, they thought that they saw capsules or some kind of tearing around these yeast structures. But of course, remember, that's very difficult. And it is useful if you do think you see capsules, it is important to do special stains to exclude cryptococcosis, which of course would be a consideration in this sort of patient. A PAS stain, which is a special stain which stains the cell wall of fungal structures, is very useful. You can see what happens here is that the periodic acid stain stains the cell wall, this magenta pink color, and now you can see the fungal elements really clearly. I can see budding yeasts very clearly here, and I think that I can also see a pseudohypha there. So I think that's really interesting. This is what was reported. This is what the histopathologist reported. They said that from this right lower leg or ankle lesion, they saw psoriform dermatitis, hyperkeratosis, melanin pigment present, some lymphocytes present, but no other inflammation, which I suppose is not very surprising given her profound granulocytopenia, at least. And then in the dermis, they see an area of necrosis with these budding yeasts measuring approximately 10 microns in diameter, with nuclei and these thick capsules, and they say fungal hyphae are absent. Just to note that the serum cryptococcal antigen test was negative, and that, of course, has a very good negative predictive value. So if we were thinking this was cryptococcosis, a serum cryptoantigen test would be quite helpful to exclude that. It wouldn't completely exclude it, but it would be helpful. Okay, so let's move on. So the patient was then reviewed by ophthalmology again. There was no sign of ocular infection, and this is really important because remember, she had that intraorbital bleed about a month prior to this. And of course, when you've got intraorbital bleed, it might represent a focus, there might be a focus of infection there. So that, that of course is really important. So on the 28th of July, they managed to get a CT chest, and I'll show you the CT chest report shortly, but they also had a serum galactomannan antigen test, which was now repeated, and now the result was 0.7, which is a low positive, or clearly positive, given the threshold I mentioned earlier. So amphotericin B was now stopped, and she was started on voriconazole. These were the serum fungal antigen tests that this patient had. So the initial galactomannan test was negative, the second one was positive, and the third was negative. But remember, the third was on voriconazole treatment. She also had a beta-glucan test, which was done on the 23rd, the same day as that positive galactomannan antigen test, and that was positive with a value of 140 picograms per, picograms per mil. So going back to that pediatric hematology guideline, what is the utility of the beta-glucan assay and PCR assays in pediatric hematology? So they are fairly clear in this guideline that they don't think there's much utility in the beta-glucan test for children in this context because of the poor positive predictive values. And also because data in children, as you would expect, are very scarce, and also because the optimal threshold for positivity is really unknown. So should you use the standard threshold of 60 picograms per mol, which is, which gets you into the gray zone, or 80, which gets you into the positive zone for beta-glucan test, or, should there be some other cutoff? Anyway, they think, no, don't use it. But they do say that if you want to use PCR, that may be useful, particularly if you're using some sort of standardized method, and particularly if you're using PCR in bronchoalveolar lavage specimens. So in terms of the patient's chest CT, multiple nodules were seen, which were diffusely distributed both in the upper and lower lobes. These nodules were equal in size, surrounded by a halo of ground glass opacification. There was also a small focus consolidation in the posterior left lower lobe, no pleural effusions, and the radiologist reported that these features were in keeping with a fungal or other atypical infection. So some really interesting data in the context of patients with hematology, principally patients with AML and stem cell transplants, essentially showing that if an abnormal CT finding, or essentially showing that abnormal CT findings are associated with subsequent diagnoses of invasive pulmonary aspergillosis. So it is a really very useful assay to perform. The problem, though, is that aspergillosis on CT scan is a chameleon. I found this sort of way of thinking about it fairly useful. So invasive aspergillosis can occur in various forms. One form is called tracheobronchitis, and this is essentially where Aspergillus invades into the trachea or the bronchial walls. And what you see then on CT scan is tracheal or bronchial wall thickening. You can also develop bronchiolitis with aspergillosis. And in this scenario, what you see on CT scan are central lobular nodules with branching or linear opacities, and this is known as a tree and bud sign. When you've got invasive or angioinvasive disease, the classical finding is these nodules or wedge-shaped opacities, which are usually subpleural, with surrounding ground glass opacification, and that represents hemorrhage. And so this is known as the halo sign. This usually happens fairly early on. Later on, what you can then see is cavitation of those nodules. That usually occurs in the convalescent sign, in the convalescent phase, and that's known as the air crescent sign. If a pulmonary angiogram is done, you can also look for something called the vessel occlusion sign. So, as I mentioned, high-res CT scans, very useful in children, but a very important proviso in children specifically is that all these typical signs that you see in adults are not seen in the majority of children with pulmonary mold infections, and radiographic findings are usually non-specific, particularly in young children. So in fact, the fact that this particular patient had such typical findings is quite unusual when you look at children with this type of infection generally. So this is usually the algorithm for triggering diagnostic procedures. So you start with a chest CT, and this algorithm is used at University Hospital Cologne, and just acknowledgement to Oliver Connolly, who shared this algorithm with me. So essentially, following on a chest CT scan, if there's suggestive lung infiltrates, the typical signs I mentioned earlier, but also if you've got non-specific infiltrates, you then would investigate further, collect appropriate samples, and do appropriate diagnostic tests. But of course, in children, you don't need suggestive infiltrates. Non-specific infiltrates are should be enough to prompt more thorough investigations. So, once you've decided you've got a high probability of invasive aspergillosis, the next step is to start targeted treatment based on these results, and the options for antifungal treatment really are voriconazole, liposomal amphotericin B, or isavuconazole. And these are the clinical trials that have really been used to provide the evidence for these recommendations. This is a very well-known clinical trial published now 20 years ago, essentially enrolled about, 300 patients or so into this trial, patients with definite or probable invasive aspergillosis, and they compared deoxycholate amphotericin B with voriconazole, and the primary outcome measure was 12-week mortality, and you can see that the hazards ratio was 0.59 in favor of voriconazole, which essentially led to voriconazole then being adopted as first-line regimen in most guidelines worldwide. The AmbiLoad study was performed a few years later, and this essentially compared two different doses of liposomal amphotericin B, 3 milligrams per kilogram versus 10 milligrams per kilogram in a group of patients with definite probable invasive aspergillosis. And essentially, they showed no mortality difference. And the 10 milligram per kilogram per day group essentially had no additional benefit and high rates of nephrotoxicity. And so, in general, the 3 milligram per kilogram dose is usually used or recommended. The SECURE trial was published most recently, and that essentially looked at isavuconazole versus voriconazole for treatment of invasive mold infections. So this was not focused just on invasive aspergillosis. They enrolled most patients in hematology with a range of invasive fungal infections, although about 80% of them did have aspergillosis. There were just over 500 patients, and you can see that in essence, the all-cause 6-week mortality was essentially similar. And isavuconazole was associated with fewer adverse events. It's a useful triazole agent because you can give it once a day. It's got linear PK with far fewer adverse events, fewer drug-drug interactions. And so it is a nicer agent to use in general. So you can see that in more recent clinical guidelines, isavuconazole and voriconazole, certainly for adults, both now receive an A1 recommendation. In contrast, in children, voriconazole is still given the highest rating, an A2 recommendation. That's really obviously because all the data come from adults. But isavuconazole has been given a tentative A2 rating, really because pediatric development is ongoing in phase 2 trials. So those are really, so voriconazole is still the main option, but isavuconazole probably will come online for children in the near future. I just want to pick up on another theme, just because this patient also had the diagnosis of COVID. So I just wanted to quickly talk about viral-associated aspergillosis, because I think it's an interesting area of investigation. So we know that if you've had a viral infection, such as influenza, you get direct viral damage to the airway epithelium, which permits aspergillus to invade. We know that viral infections hamper ciliary clearance, and that can facilitate aspergillus colonization. And also, both the viral infection and the ARDS, which may be associated with severe infection, can lead to immune dysregulation, dysfunction, and that can lead to aspergillosis. And influenza-associated invasive aspergillosis can either involve the lung tissue or can involve the trachea and the bronchi. And this is obviously tracheobronchitis. Interesting to see that in a cohort of patients with COVID-19 who are being mechanically ventilated, those with a probable diagnosis of kappa or COVID-associated pulmonary aspergillosis had worse outcomes in this small study here and in another cohort study that was also done. The problem with COVID-associated kappa or COVID-associated pulmonary aspergillosis or kappa is that it's very difficult to make the diagnosis, principally because patients with COVID don't have typical host factors that you usually see in the hematology setting, nor do they have the typical radiology for invasive aspergillosis that you see in the hematology setting. Also, fewer bronchoscopies are done because of the risk to healthcare workers, and so there are fewer bronchoalveolar lavage specimens available, and so it's much more difficult to make the diagnosis. In 2020, this paper was published just trying to define kappa, and they came up with this algorithm, which at first glance is completely impenetrable. When you look at it, they've essentially used all these little icons to try to simplify the diagnosis. But I think what you can appreciate is that it's really not very straightforward. Proven kappa is probably the most straightforward, where you have tissue biopsy and you can demonstrate clear tissue invasion on histology, or if you can have a positive culture from a tissue biopsy specimen, or positive PCR from a tissue biopsy. But once you get into the realms of probable and possible kappa, I think it really is very, very difficult. And the only way you probably will be able to work out if it's probable or possible is by consulting this difficult to read figure. So in terms of recommended treatment for kappa, it's essentially just based on expert opinion and doesn't differ very much from treatment of patients with hematological malignancy. So voriconazole, isavuconazole. So let's go back to this patient. Meropenem was stopped on the 3rd of August, and she was started on liposomal amphotericin B. She was now on both liposomal amphotericin B and voriconazole, and this was again because of her temperature that has continued to spike. I suspect at this point they had the results of the skin biopsy, so I think they might have added on liposomal ampho B for that reason, to kind of cover a yeast infection, which is reasonable. So just in terms of her antifungal treatment, she'd initially started off on fluconazole. She then had received liposomal ampho B, then voriconazole, and then at a later stage, micafungin. This is just a quick summary to show you the first line and alternative cover for invasive mold infections. I'm not going to, obviously I never remember any of this, but I think it's quite useful to have this sort of figure available for easy reference. Every time anyone asks me about a rare infection like a Scopulariopsis infection, for instance, I usually have to look it up. It's not something that sticks in your mind. Duration of antifungal treatment in invasive mold infections. The bottom line is it's really an individual decision. And if you're treating invasive aspergillosis, for instance, in a patient with a hematological malignancy, it would be for a minimum of 4 weeks, usually a medium of 12 weeks, with no maximum. So going back to this patient, she had a repeat skin biopsy performed by dermatology. This tissue was not sent for formal histology examination, but in fact, the biopsy was only sent to microbiology, which, as most of you will know, is fairly unusual. This time, she had positive fungal cultures on that skin biopsy, and I must be honest, the results were unexpected. From the fresh skin tissue on the 5th of August, Candida albicans was isolated in culture. And when we at NICD performed direct PCR on that tissue sample, it was also confirmed to be Candida albicans. But this was completely unexpected. They'd also done a rapid on-site microscopic evaluation, which was negative for yeasts. And the patient had been on broad spectrum antifungal treatment, as I've shown you, that would have absolutely covered Candida albicans. So what I then suggested is we go back to that original skin tissue sample where those budding yeasts had been seen on histology. And we then performed PCR on that FFPE skin tissue. And this time we found Candida parapsilosis, which I think might be consistent with this patient's infection. It might have been an azole-resistant Candida parapsilosis. And of course, remember that acute candidiasis can present with tender red macules or plaques on the skin, often with multiple lesions, usually with no central eschar, even though you might get ulceration, and the diameter classically of less than 1 centimeter. And that fits fairly well with what this patient had. It's important, obviously, to do blood cultures, punch biopsies, and exclude deep organ involvement, of course. Delayed treatment of invasive candidiasis, as we all know, increases mortality. And so, the problem, of course, is if you don't have these skin lesions, this patient's diagnosis could have been missed. This is another patient with a hematological malignancy where this patient had a Candida spondylodiscitis and a paravertebral abscess, which was seen on CT PET scanning and MRI scans. As you know, candidemia is usually treated with echinocandins, and that's usually fairly straightforward if you've got positive blood cultures. But a large proportion of patients will have negative blood cultures, as in this particular patient. Treatment, of course, echinocandins, and then often step down to fluconazole if the isolate is susceptible and that the patient is stable, and the total treatment duration is usually a minimum of 14 days after the end of candidemia, which means after the last negative culture. Another table, again, just for reference, and including all the rare yeast infections, which you can see in patients with hematological malignancy. So we most often see Candida and Cryptococcus, but there are all sorts of other rare yeast infections which can also cause infections. Some other investigations that were also done in this patient, the CT head and an abdominal ultrasound, didn't show very much. The abdominal ultrasound was pretty much negative apart from a mild hepatomegaly and ascites. CT brain was essentially normal also, although they did notice a pacified paranasal sinuses. I don't know what that means. In terms of this patient's further course, colistin was stopped. She was then later changed to liposomal amphotericin B, but she continued spiking her temperature. And in fact, a few days later, had several blood cultures positive for Klebsiella pneumonia, Acinetobacter baumannii, both of which were multi-drug resistant. Meropenem was restarted. So just in summary, this patient had an aplastic anemia with profound and prolonged bone marrow suppression, several episodes of healthcare-associated infections caused by multi-drug resistant organisms. She had multiple risk factors for invasive fungal infections. She wasn't on antifungal prophylaxis. In terms of her diagnosis, I think that she had proven invasive candidiasis despite negative blood cultures and non-response to broad-spectrum antifungals. Remember, she was initially on fluconazole, then amphotericin B, and later micafungin. And this is really based on the skin lesions with the refractory fever, and also really because we found Candida in the skin tissue biopsy, both on histology and also culture and PCR. So Candida is almost certainly one of the main driving infections here. She probably along the way also had a probable invasive mold infection with that refractory fever, with the typical CT chest findings, and also with the elevated serum galactomannan. We're going to choose to ignore that beta-glucan test because of the positive predictive value. And even though she did have COVID, there's no clear evidence that this invasive mold infection was related to COVID. It was a very sad outcome. She had no clear clinical improvement with ongoing low-grade pyrexia. The pediatric oncology team agreed on a palliative approach with the family. The patient was discharged, and after 3 days at home, she started bleeding from her mouth, and this progressed very quickly to decerebration with a presumed intracerebral hemorrhage. I'm going to end there, but just to say thank you very much to Juanita Lishman and Clinton van der Westhuizen, who shared the case and laboratory information with me, and then also to thank Professor Oliver Connolly from Cologne University, who shared some of his slides with me. Thanks very much.
Thanks, Nelesh. It's a sad outcome, but a really incredible talk that you've gone through so much of fungal infections and neutropenia, really in this one case. As you said, it's lots and lots and lots to think about. Any comments, just please put it in the chat, or any comments or questions. I think, from my side, I will say that it's very, very different, the clinical care of neutropenic patients compared to the non-neutropenic, and it throws your intuitions a lot. I found this, when I studied it, it's very like if you think HIV, it's not easily transferable across to neutropenic patients. It's a totally different set of immune problems and things. And I think you did mention this, but just to kind of reiterate for the audience, I mean, a chest X-ray is next to hopeless in a neutropenic patient, profoundly neutropenic. Most of the infiltrates you see in a pneumonia are from the neutrophils, in fact. So you really do need to get CTs early. And then, as this case kind of showed as well, don't tolerate empiric therapies for long. In other words, you have to often start them because they're very sick and they can go wrong. But you've got to go hunting as aggressively as possible for the bug, because it's just too broad and too difficult. So as you said, that skin biopsy, when they send for histology, phone their consultant, get them back, get them to do the culture the next day. In this patient with stuff in the lungs, really, I mean, there may have been many patient-specific reasons why it was very difficult, especially with the very low platelets. But ideally, obviously, bronch that patient, get the culture back that way too. And if not, so you've got stuff coming in. It's very hard and it's very different. So many times with the rest of medicine, you can try empiric, and if it fails, you've got a bit of time. And these guys, you really don't. It's very, very tough, but incredible case to think through. And you've covered pretty much absolutely everything in terms of this one single case. So that's fantastic, Nelesh. It's brilliant, brilliant. I see Lucille's put on the chat there as well. You are a fungal master. That's brilliant. Any questions or comments or any? And there's one question that's just come through. I'm just going to read. Okay, there's actually two, but maybe you can take the one that's on there about the lack of response to VORI and AMFO?
So, Nosiso, I think that she probably had, and there was also a complete lack of response to the fluconazole, even though we probably were dealing with so the fluconazole lack of response to that might be explained by azole resistance of the Candida parapsilosis. But in terms of the voriconazole and amphotericin B, I think they were probably appropriate to cover the infection, but I suspect that she just had such an overwhelming infection that she probably didn't have much of an immune system. There was no immune system to help that antifungal treatment to control that fungal infection. So I would think that's probably the main reason.
Yeah.
You're just not winning because you had really broad spectrum cover, but it was probably just overwhelming infection.
Yeah.
And also, she did have multiple infections.
Agreed. And there's a question, did she have central lines?
I'm almost certain she did. If Clinton is on the call or Anita, maybe they can just, I'm almost certain that she must have had I don't think she had a port in place, but she almost certainly had a central line.
Okay.
And then, of course, you would consider all these yeast infections, particularly some of the rare yeast infections. You'd worry about Candida parapsilosis, but you'd also worry about auris in Gauteng in particular, but then rhodotorula and various others, which we do see in hematology patients.
And then there's Alicia's got some questions. I just want to ask one other in the meantime. Eunice asked, should chronic neutropenia secondary to aplastic anemia be approached in the same manner as chemotherapy-induced neutropenia? So I guess in terms of prophylaxis and aspects like that.
So Eunice, I'm certainly not an expert in this area, and I'd probably have to defer this to a hematologist. But I think that your risk with prolonged, profound neutropenia, certainly for invasive fungal infections, certainly will increase. I don't think the guidelines include aplastic anemia, possibly because it's not that common. But I would have to defer to a hematologist. I'm not certain.
Or an ID doctor.
Or an ID doctor, yes. Thank you.
This one would, so no, I'm kidding. So I'm just unmuting Alicia there. I think for the aplastic anemias, it is dependent on obviously the neutrophil count because they vary a lot. But in these very profound cases, where it's less than about 0.2, 0.1, it is recommended. So the patient ideally should get some form of chronic antifungal therapy. The issue is obviously what, and like Nelesh said, it's Candida at a minimum, but you may well go beyond that in terms of the molds too, if you can, but it may be difficult in the state sector as well for long term. Alicia, you've got your hand up. Sorry, will you asked to unmute?
Yeah. Good afternoon, Prof. I'm funding in from Bloemfontein at the government sector and currently having a very challenging case, a 14-year-old with B acute lymphoblastic leukemia who's been neutropenic for more than 7 days. So we've got this through more than 7 days on broad spectrum antibiotics and still having fever spikes. Think about fungals. So his HRCT has got significant invasive fungal infection. My main problem is getting biomarkers and lavages and biopsies. Is there any place for shotgun medicine adding AMFO with VORI, with mycofungin until this patient is really in trouble. Is there any antagonism between AMFO and voriconazole? Yeah, basically, what is your opinion about that?
If you can't make a firm diagnosis, Alicia, I think broad spectrum antifungals are reasonable and covering for both aspergillosis and mucormycosis, which are probably the most common of the infections you'd be expecting in this sort of patient, I think is reasonable. Obviously, it would be nice to make a diagnosis, but you don't, or you aren't always able to make a diagnosis. So I think broad spectrum cover is reasonable.
But Alicia, push for the bronch, right? I mean, if you're looking after neutropenic patients, they have to be able to do it. Otherwise, as you said, it's hard. You can start empirically, but it's very, very difficult. And then Nelesh, you've got a comment at the end there about what did you make of the thick capsule in the biopsy?
Yes, I saw that in the histopathology report. I think it might have been an artifact. I think that with tissue retraction, you sometimes see what appears to be a capsule. And, if there is a capsule, like I said, it's always useful. If you think there's a capsule, it's useful to do special stains. A mucic carmine, an alpha blue stain can often, take you towards cryptococcosis rather than a candida infection. I think this was, just from the sections I saw, I think this was really consistent with a candida infection because there were budding yeast as well as I saw what I thought was pseudohyphae.
Cool. I think that's it on the questions. There's lots of comment in the chat and many people thanking you very much, in which I can only add to. So it was a real masterclass you've given us today. So thank you so much, Nelesh. And I'm going to